Let's get started. Disclaimer. All right. Okay, so what is osteoporosis? Well, as you know, it's simply a loss of bone mass, but also the structure. And you can kind of see that pictured out here. You've had a DEXA scan, more than likely, and they spits out a number and it puts you on a scale. And if you're less than minus 2.5, you have osteoporosis. Okay. So how do most people get osteoporosis? Well, primarily, you get it from just aging, right? We build bone mass when we're young until we get, roughly 30 years old. And then the bone mass starts to leave us, right? And it's a natural aging process. And you can see for men, it's kind of a gradual drop off. But for females, around 50 years old, when you enter menopause, you lose a valuable component in the bone building equation, which is estrogen. So you take a big hit when you lose estrogen, and there's some things you can do to kind of smooth out that curve, and we'll talk about those. But that's typically how people get osteoporosis. So that's the primary cause, loss of estrogen. And for males, loss of testosterone. And a lot of males don't realize this, but testosterone gets converted in the male body to estrogen, right? We don't have as much as females in general. And that estrogen is used for building bones. So males have to watch out for that. And then also as you age, your body or your bones will what's called turnover or remodel quicker. And we'll talk about remodeling and what that all means. But the bottom line is quicker isn't necessarily better, especially if you're losing bone mass every time it cycles. So we'll talk about some of those details today. And then now there's a secondary way to get osteoporosis. Secondary causes for osteoporosis is a clinical disorder or some medication that you might be taking. The top two kind of clinical disorders are hypercalciuria, where you're urinating out too much calcium, or hyperparathyroidism. And we'll cover what that is, but those are the most common causes of secondary osteoporosis. You have other factors like diet, right? Maybe I didn't get enough calcium as a kid or enough vitamin D as a kid, and you never made it to that peak. Well, that'll hurt you later in life when you're losing bone mass. Medications, glucocorticoids are really known for being hard on the bones. Blood thinners, anticonvulsants, there's various drugs that will do that. And diseases, celiac disease, right? Malabsorption disease, hypogonadism, hyperthyroidism. There's various diseases too that you can pick up that will affect your bones. And then finally, really the big kind of takeaway here is there's a big genetic factor in this. About 50 to 85% of the individual develop osteoporosis from just genetic factors. I happen to be in that camp. So anyway, we'll talk about all these as we go through the presentation. So where to start? And like Julie said earlier, you really want to find a good doctor team, right? You probably heard from your primary care physician, hey, you've got osteoporosis. You ask, what does that mean, right? And their knee-jerk reaction, and I heard it earlier from one participant here, is, well, we'll give you a Fosamax, right? Try that for a while, and we'll test you in a year or two. Wrong. That's the wrong approach when you first find out you have osteoporosis. You have to do some testing. You have to look for some of these secondary causes before you start treatment. And you'll see why. And really what you want to do is try to get on your team an endocrinologist that specializes in osteoporosis. They'll be the ones that are going to these trainings that get the latest information, assuming one that focuses on osteoporosis will be in those trainings, and they'll know what the latest and greatest is to do that. Okay, so try to get that person on your team. And when you do, this is a list of almost a bare minimum list of what should be checked before you start treatment, right? You're looking for these secondary causes. And if you have a secondary cause, if you can fix it, right? Whether it be from diet, low vitamin D, Maybe you have hypercalciuria, maybe you have a parathyroid issue. Get that fixed first, and you're going to have much better results on your treatment. Or you might not even need treatment, depending on kind of what the factors are. We'll talk about those. By the way, in the backup, I've put a list of kind of the full list from the official guide, the Association of Clinical Endocrinologists, in the backup. So you can see all of the tests that are kind of out there. But these are the big ones that really should be done for everybody. Okay. And it's not just blood test, it's urine test, right? You need to see if you're urinating out too much calcium, as an example, right? Because that's another big reason why a lot of people have osteoporosis. So make sure to do that. All right, so that said, what I'm going to do is walk through the next 3 slides are kind of like your system, your body, and how the system works and how these secondary causes might cause an issue for you. And we're going to start with the calcium system. So that's you on the left there. You might look a little bit different in the mirror, but this is you on the left. And you have, a blood pool, heart, pumping veins, all that type of stuff kind of circulating throughout your body. And what we're going to do is we're going to look at a day of 1,000 milligrams of calcium. So we're going to take in 1,000 milligrams in both food and supplements combined, right? A total of 1,000 milligrams. When you do that throughout the day, you'll absorb about 400 milligrams of that, which is typical. That's basically, well, actually, that's pretty high, but regardless, that's a good number. Of that 400 milligrams that gets into your blood supply, about 200 gets kicked back out into the gut, right? Into the small intestines or large intestines. So that's okay. That's the way it's supposed to work. So that gives you like a net 200 milligrams going into your blood system that can be used by your body. The rest of it, you basically poop out, and that's okay. All right. So now we have this circulating calcium, and it will circulate through your bones. So this calcium comes to your bones. Your bones are constantly in a state of remodeling. And what that means is they're doing like micro repairs. You have, we'll get into these details, osteoclasts and osteoblasts. These are 2 structures that will eat into your bone to release calcium, and then also take calcium from your bloodstream and put it into bone. Now, if, like when you're growing, you're taking in more calcium than you're kicking out, you're gaining bone mass. Life is good. When you hit about 30, it becomes, equal. And then as you get over 30, every time that repair cycle happens, you lose a little bit of bone. And that's called bone loss. All right, let's go back to bone balance. So we have 200 milligrams going in, about 200 milligrams coming out, right? A net zero type of thing. Well, that will be flushed out. That 200 that you took in for the day will be flushed out through your kidneys. Okay, some of it's going to be bone, some of it's going to be from the calcium that you took, but it'll come out your urine. All right, so what could possibly go wrong here? All right, let's start with the easy stuff. You're not taking 1,000 milligrams, right? Or 1,200, the recommended daily amount. You're not getting enough calcium to even get this thing rolling properly. Perhaps you have a problem with ingesting. Your 400 milligrams is only 200 milligrams or something to that effect. So you might have a malabsorption issue. There could be plenty of things going wrong in this kind of bone area over here, but we'll get to those. And then lastly, one of the big ones, hypercalciuria, where your kidneys aren't reclaiming the calcium that they're supposed to, because your kidneys will filter your blood and calcium. It filters like 20 grams of calcium throughout the day. Of that, it reclaims it and comes back into your blood system. Well, if it's leaking, as an example, I have hypercalciuria. I urinate out about, well, before I got on medication and doing a couple other changes, I was urinating out about 550 milligrams a day. I had no chance at building bone at that point. So you have to fix those types of things before you start treatment if you want to see good results. Okay, let's talk a minute about vitamin D. So here we're taking vitamin D. It's getting into our blood system. Now, this vitamin D that you take isn't the vitamin D that's used with your bones, right? It has to be converted into a usable form. And what the vitamin D will do is it'll get in your bloodstream, it'll go through your liver, and it'll be converted to what's called 25-OH vitamin D. Now, this is what gets checked on those blood tests, right? And everyone, hey, what's your vitamin D levels? And you read them off. This is that form of vitamin D. And it's called the storage form. It gets stored throughout your body. It's not used by your bones, not yet, but it's stored throughout your body to be used. And it moves real slowly. So you take vitamin D, that the storage might come up a little bit because you have a whole bunch in your body that's ready to go. And it goes down a little bit. We'll talk more about vitamin D. All right, so it still has to be converted into a format that's usable. And what it does is it goes through your kidneys. Your kidneys will then take that vitamin D, the storage form, and convert it to what's called the active form, 125 OH dihydroxy vitamin D. And this is the stuff that's used throughout your body. Your kidneys will receive a signal when your body needs more of this. And we'll talk about that control signal in a minute. But this active form of vitamin D is what's used in your bones, right? It helps the process, both the building and the tearing down. It helps everything flow over there really well. It also will get back to your gut and have you absorb more calcium. Okay, so that's a great thing. And also your kidneys. It'll tell your kidneys once you start producing this to reclaim calcium from your urine and put it back into your bloodstream. So that's kind of how this vitamin D helps. So what could go wrong here? Well, I don't know what the statistic is, but it's a really high number of people in the United States are deficient in vitamin D. And that's that blood test result that I'm talking about, the 25-OHD. So that's one problem, right? For the most part, it gets absorbed. I don't think you have to worry about that too much. But perhaps your kidneys have a difficult time. They're not turning on right, or they just have a difficult time converting that storage form to the active form. So that could be a problem. So there's a couple things that can go wrong here. And finally, I want to talk about your parathyroid gland. So this is the control system for the calcium in your body. It's the primary control system with a feedback loop and everything. And your thyroid resides, right up here at your neck. And behind the thyroid is a parathyroid gland. You have 4 of them. And what it does is it senses the calcium in your bloodstream. And it says, hey, Mike's got low calcium. Let's generate this parathyroid hormone, put it into the bloodstream, and get more calcium into the system. So this is the signal that gets sent to the bones and says, hey, bones, I need calcium. Start chewing up some bone here and give me the calcium out of your bones. So that's one thing it does. The PTH will go to your kidney. And this is the signal that says, hey, I've got an alarm here. I need more calcium. Generate 125-OH vitamin D, the active vitamin D. And it salutes and it starts producing it. And it also starts reclaiming that calcium from your urine. Again, trying to get your blood calcium levels up. And then finally, that active vitamin D makes it to your gut and you absorb more calcium. So when you take calcium, it'll absorb more. That goes up, that absorption number. So it's kind of like a all hands on deck signal that says, get calcium into my blood system because it's too low. It's very well regulated. So what could go wrong? And this takes us to, one of those top 2 reasons for secondary osteoporosis, which is your parathyroid gland, those 4 glands, they can get kind of out of whack. So you get like a tumor on them. It's not really cancerous. It's an adenoma or something like that. But it'll grow unnaturally big and basically start leaking parathyroid hormone. It still works. It's just everything is like juiced up. And the good news is it's pretty easy to detect for most people. And you can see it on your blood test. If you look at your blood test and you look at your calcium levels and the number is 10 or above, then there's a really good chance you have a parathyroid gland that's out of whack. And you might say, oh my God, that sounds horrible. I was hoping for this because there's actually a cure, and it's just cutting out the gland that's kind of out of control and then bam, within a year, you've gained 1 or 2 T-scores. I mean, it's incredible. And life is good, right? Problem solved. So that's kind of the primary thing to look for here, and that calcium level is really important in your blood test. So what else could go wrong here? Well, parathyroid signal gets to your kidneys. Kidney says, I'm not going to make 125 OH, forget it. It's not an alarm, right? You want that active. You want to make sure that that gets checked at least once throughout your journey. With any luck at all, your endocrinologist will order that test. And again, it's kind of on that sheet there. Okay. All right, so that's the system there. Okay, so let's talk about medications. So we've gone through, we've found some secondary issues, we fixed some vitamin D levels, we're taking more calcium, right? You've had your blood test, your urine test, you're ready to move on. Now you've got to make the big decision on, God, is it worth taking medications? All medications have side effects. All medications have risk, right? All of the trainings that I've been in, the doctors, now granted they're bone doctors, right? This is their job. They say it's worth the risk because having a fracture, the risk of fracture is reduced more than kind of your risk of a side effect. Not saying you're not going to have one. The people that do get them, they regret it, right? But it's few. It's rarer than most people think. I'll leave it at that. So there's a couple tools here to help you make that decision. This is a chart that I got off of the 2005 Osteoporosis Canada 10-year fracture study assessment, and it tells a really good story. Let me start with, okay, let's say you're 55 years old and you have a T-score of -2. You're in this low risk of green zone and you think, hey, you know what? My risk of fracture is really low. I'm not going to do anything. All right, there's 2 problems with that. One, even if you stayed at -2 on your T-score, as you age, your risk of fracture goes up. Now, why does it go up? Well, because you're losing muscle mass, right? You might not be able to hang on to that thing when you're falling or brace yourself before you hit the ground, right? You're losing mobility. You can't turn as much to catch yourself. Your sense of balance starts to go away, right? Maybe you're not making the best decisions when you get older and you shouldn't have gone on that roof to do the repairs like I keep doing. So there's various factors that increase your risk of fracture, even at the same bone density. But you're not going to keep the same bone density, right? You will continue to go up. And if you've just left menopause, you're going to go up pretty quickly into this moderate risk or even high risk zone. Okay. So that should, help you understand kind of what some of the risks are here. And then also there's this tool. And as a matter of fact, if you look at your DEXA report, you'll see this red box in there somewhere that gives you a 10-year probability of fracture. And that's based in a point in time, based on, a limited scope of things, right? Or factors. And so this is a tool you can run yourself. I run it for mine. I got the same numbers that was on my printout, so life is good. But what I did is I ran an example here. 75 years old, female, 150 pounds, 5 foot, 5 inches tall, had a previous fracture, had a parent with a hip fracture, but doesn't smoke, not on drugs, right? Doesn't have arthritis, no other secondary causes, right? Those have all been checked, and you don't drink alcohol. And the T-score in the femoral neck was -4.1. This person, fictional person, would have a 79% chance, roughly 80% chance of breaking a spine or a hip or something, major like that in the next 10 years. And oh, by the way, if you stay at this T-score, the next year goes up, the next year goes up, and your T-score is more likely going down. So, this is going the wrong direction every year. So this is something that you can do. And oh, by the way, when you get a DEXA scan, ask them if they can do a trabecular bone score or TBS score. And you can see there's a button here at the bottom that you can click on. And what that does is it gives you an assessment of your structure. right? Whether your structure's really sound, you still have all the honeycomb, or whether you've got some patches of holes and stuff like that. And it can, either improve your chances or reduce your chances of fracture over time. But you have to ask for it. Not everyone will do it. All right. So let's talk about the drugs. And this is toe in the water. Yeah, calcium's not really a drug. It's a mineral, right? We take it every day. We eat it in our foods. And here's the recommended daily amounts from the NIH, National Institute of Health. And 1,200 is kind of the magic number here, right? And that 1,200 number is for both food and supplements, okay? And if you're getting all your calcium from food, right? You're a big dairy person, you drink a lot of milk, you eat yogurt, you have cheese. That's great. That's really the best way to get calcium, right? And there's a lot of calcium fortified, drinks and foods and such out there. But if you can't hit that target, right, then you want to supplement to get up to that. Now, here's some tips to kind of help you, figure your way through here. 8 ounces of milk or 6 ounces of yogurt is about 300 milligrams. Okay, that's pretty, that's a quarter of what I need. A slice of cheese is about 200 milligrams. Okay, so the idea is use those guidelines, look at the food, right? Almost all food has calcium, to figure out, where you're at, and then supplement around that. Now, as far as supplements go, there's different types of calcium. Calcium citrate absorbs better than all the rest. And as a matter of fact, you don't even have to take it with food. Now, if you take it with protein, you'll absorb even more. But regardless, it's the quickest, most effective type of calcium from what I've found. And I have some charts in the backup that shows that. But remember, if you are taking something like Citracal, calcium citrate, and it's fortified with vitamin D, and you're relying on that vitamin D to kind of get, your vitamin D for the day, just know that it has to be taken with a fat, right? Like nuts or any kind of food with fat, with milk, right? To absorb, because vitamin D is a fat-soluble vitamin. And then finally, don't take all your calcium at once, right? If you're eating all your dairy in the morning when you first get up, and then you take a supplement with it on top of that, and you say, I've got 1,200, I'm good for the rest of the day. You don't want to do that. You lose the efficiency of the absorption to do that. Spread it out throughout the day. Okay. I do with each meal. I kind of supplement here and there and adjust depending on what I have for food at all meals. All right, let's switch over to vitamin D. So this can get confusing. So what it is separate them into 2 different kind of buckets here. The vitamin D that you take, and there's a recommended daily amounts that more than likely you're taking more than this, and that's okay. But really the target, the recommended from the same NIH group, is about 800 IUs per day, which is 200 micrograms or 20 micrograms a day. Okay, that's all good and said. But really what you need to focus on is this 25 OH level, the level that's on your blood test. And what I've done, it's tough. This is a moving target depending on which doctor you talk to. They give you a different range. What I've done is I've gone through a whole bunch of documents here from the NIH, from the Endocrine Society, the Institute of Medicine, and then also all of the trials and studies, and I've read hundreds of them. They all say, hey, you got to get to 30 nanograms per milliliter. And if you're not there, typically what they'll do is they'll give you bolus doses, big doses, 20,000 IUs for a week or something to get you up there. And then you level back down to, say, 1,000 IUs a day, something to that effect. But really what you want to do is get in this range of about 30 to 50 nanograms per milliliter. Now, be careful. Your blood test might show it in different units. And that's this NMOL, or nanomoles per liter. They're similar numbers, and that's why I've listed both of them here. Try to get between 30 to 50 nanograms per milliliter, or if your units are different, 75 to 125 nanomoles per liter. Okay. And if you needed more evidence, I found these other two charts down here, which are pretty interesting. And it shows your PTH level versus your 25-OH vitamin D levels. And you can see if you're below this 30 number or 75 number, right, your PTH starts to rise. And that's not good for bones. You got to make sure you hit, get in that threshold area. Now, the flip side is the Institute of Medicine says, hey, greater than 50 indicates risk of harm. And I found this chart here that shows that, believe it or not, too much vitamin D can increase your chances of falling. I don't know if it slows down your reactions or makes you stupid. I don't know what exactly it does, but regardless, your chances of falls goes up. And you can, by the way, all of these slides I've put footnotes on. So I'm not making any of this stuff up. You can look at all these studies and all this data is footnote, so you can look at it. Okay. Bottom line, takeaway, take as much vitamin D, right, orally that you need to get in that zone. And just know it changes slowly. It might take a month. It might take 2 months to settle down. So if you're at 20 and you're taking, say, 1,000 IUs already, go up to 2,000. Wait a month, see where you're at, right? Basically, every time I go in for a blood test, I say, hey, let's check the vitamin D levels. And it helps me adjust that. Okay, so this is actually a drug. Vitamin D turns into a hormone when it's processed. So keep that in mind. All right, but now we're going to move into the osteoporosis specific medications. And they're kind of split into two classes. There's the anti-resorptives, which are your bisphosphonates, Fosamax, Reclast. I forget the names of the other ones. There's hundreds of these actually. But these are the big two. There's also what's called a rank ligand inhibitor, which is Prolia. Okay, the medical name is denosumab. And those medications will build bone mass. So your bones will get thicker, but not necessarily that structure that's inside. So that's good, but on the right-hand side, it'll do both, right? It'll build back the density as well as it'll start to build back that structure and give you more strength. And they're also very fast acting here on the right-hand side. And we'll show you when to use these versus the ones on the left. But there's what's called PTH analogs, Tymlos and Forteo. And then there's a sclerostin inhibitor called Evenity. And we'll get into gory details on these if you stick around long enough or stay awake through that part. But it gets pretty technical. Lastly, and we heard this earlier, I was so happy when this participant was talking to Elaine and she said, yeah, I've heard that if you take these out of order, they're not as effective. That's absolutely true. You want to make sure you get the order right. And I'll show you some examples of that. But just quickly, you want to be on the right-hand side first. If you need them, then move to the left-hand side. If you do it the other way around, the right-hand side, the osteoanabolics will be less effective. And that's kind of the key takeaway here. Okay, so let's talk about this. How do these medications perform? How do I know if this is a good medication for me based on where I'm at? Well, this is a chart, and you'll probably never find one like this. But what I've done is I've gone through all of the major clinical trials for each one of these drugs and pulled out the improvement in lumbar spine, the hip, and how many years it took. Now, granted, all of these trials are a little bit different, so kind of keep that in mind. But for the most part, these are good numbers that you can lean on. And what you see is you say, okay, let's start with the bisphosphonates. You have Fosamax, right? Alendronate, Reclast, zoledronic acid. It's an infusion. Both of those drugs will get you about 10% in about 5 or 6 years. So that's good, right? 10% is about equivalent to 1 T-score. So if you're at -3, these drugs will take your lumbar spine in about 5 or 6 years down to -2. Okay, that's the type of performance you can get from these. Now on the hip, if you're at a real high T-score or low T-score, this 3.5% and 4.3% 5 and 6 years, this is the maximum that you're going to get out of these. If you take these more than about 3 or 4 years, your hip bone density or your hip bone density will start to go down. Now your spine will continue to go up. You maybe get up to 14, 15%, but your hip will start to go down. So there's limitations on bisphosphonates, and you have to be careful, because doctors love to just say, let's put you on Fosamax, or let's give you a shot of Zol. That's what my doctor told me. Wrong, wrong approach. All right, then we move into Prolia. So Prolia, boy, a lot of people have heard horror stories about Prolia. Once you start it, you can't get off it. That's not true. We'll talk about that. I have a whole presentation on Prolia. But regardless, Prolia is a wonderful drug, right? If we look at the performance, after 5 years, you can gain 13, almost 14% in your lumbar spine. That's almost 1.5 T-scores. And your hip, basically twice what can be done on a bisphosphonate, so about 7%. And the beauty of Prolia, unlike the bisphosphonates, is, hey, let's look after 10 years. So this is 10 years straight. You've gained 2 T-scores in your lumbar spine. You've gained almost a full T-score in your hip, and it's still going up, right? This is the only medication that you can take on a long-term basis that will continue to work for you. So it's a wonderful drug, and I'm actually on it now. I'll show you that later. And then finally, when we talk about the osteoanabolics, these are the emergency ones, right? These are the ones you can only use for like a year or up to 2 years, maybe, depending on the drug. But you can get, in the case of Forteo, 10.6% in your lumbar spine, 3.2% in the hip in 1.5 years, right? So 18 months, you've made a big stride. This gets you out of that danger zone. Likewise, Tymlos. Tymlos is a improved version for the most part. It's a more evolved. It came out after Forteo. It was kind of a fine-tuning of that type of medication. And you get better performance. And the side effects are roughly the same, almost identical on both of those. So 11%, 4.2% in that same 1.5-year time frame. And then finally, this Evenity drug, you get about 13.7% in the spine, 6.2% in 1 year, right? I've seen studies where people get 18%, and there's also people that get less, especially if you have a secondary osteoporosis issue. Okay, so this is kind of a snapshot of the drugs. This is a handy table to kind of have. And this leads me into what I call the most important slide in this presentation, right? This is the one you print out, you understand, you take to your doctor, you show it to your doctor, and let me explain what's going on here. So I won't say stole this. I took a version from Michael McClung, Dr. Michael McClung. He was presenting at the 9th Central European Congress of Osteoporosis. And I added a lot of stuff to it. So I modified his slide, and then I actually sent it to him. And he replied back and said, yes, that was what I was trying to convey. All right. So what it's showing you here is, let's pick a point. So let's say you're minus 3.7, minus 3.8, or minus 4. Let's start with a lumbar spine. You're in a very high risk of fracture, period. I don't care what age you are. You want to get out of the zone as quickly as you can. And to do that, you really want to be on Evenity, Tymlos, or Forteo, right? Those are the big 3. You should be able to get it. If you're above minus 3.5, I'm at minus 3.7, right? When I started treatment. I'm a male. Evenity is only, what do they call it? Qualified or specified for females, though there's plenty of male trials that show that it works just as well. I was able to get my insurance to cover Evenity for me. And I haven't had a prior fracture. I'm at minus 3.7 when I had this done. So you can do it. Push your doctors. If they push back, you push back on them, right? I got to the point where I was writing my own letters to the doctor to say, here, submit this to the insurance company. I've even helped some members do that. But regardless, do what you can to get there. If you can't get there for whatever reasons, Prolia is really your only other option at this point. Right? You could take the other drugs, but it's not going to get you where you need to be. Prolia is the next best solution here. All right, let's move down into the high zone. You know, maybe you're at like minus 2.8 or minus 3. Really, again, because you've lost that bone structure, if you can get Evenity, Tymlos, or Forteo, do it, right? Those are going to be the drugs that'll move you quickly. If not, Prolia, probably, but you might, you know, if you're on the lower end, minus 2.5, minus 2.6, you know, alendronate might work out for you, especially if your hip is okay and it's just your spine, because, you know, alendronate works pretty well for that. Or reclassed, right? The same type of bisphosphonate. And then as you move down, so in the medium zone, now you're osteopenia range, and you're saying, okay, well, what's the right drug? Well, you know what? Probably alendronate is a great drug for this, right? You take it for, you know, a couple of years, 3 years, get another T-score, see where you're at, make a decision. Reclassed, another great example, another great solution for you. Or maybe Prolia, right? If you're at that higher end and maybe you've tried bisphosphonates and they just, you know, haven't got you there and you're kind of scratching your head and what you're going to do next, Prolia is probably your kind of next go-to. And then let's take kind of best case scenario here. My wife happens to be in this case scenario, and she's fine. She doesn't even have osteopenia. But you know what? As soon as you enter menopause, the estrogen goes away. These numbers can shoot up very quickly. So what we did with her is we started her on estrogen therapy. Estrogen actually works a lot like Prolia does. And it has the same issues where if you get off of estrogen, then your you know, bone density can crash, so you need to take a medication after that. But regardless, estrogen's a great solution in this space. As a matter of fact, I'm kind of on it myself. I'm taking testosterone medication to raise my testosterone, which raises my estrogen. I'm kind of in this camp myself. And you can do this in conjunction with all of these medications. There's no reason why you can't do that. So it's something to consider. I have a couple slides on estrogen that we'll talk about at the end of the presentation. But the idea is once you're in this low zone, right? Once you make it here, then you can switch to the bisphosphonate type of solutions, alendronate. And what Mike McClung had recommended that really stuck out for me is this 3 years on alendronate, and then you take 2 years off, no medication, right? Let your bones kind of regroup. And then you go back on it, and then you take another vacation on it, on drug. And you'll see your bone density kind of, you know, get better and then get worse and then get better. And that's okay. You're staying below 2, and below 2 is a really good strategy if you can get there. Okay. Again, all of the numbers here on the left will help you decide what makes sense, or on the right. And the hip score, if you're at a real high hip score, well, then you've got a lot of work to do, because these medications, because the hip is less active, there's less kind of area on the bone itself. These drugs don't work as quickly. It's harder to move that, it's called cortical bone, that hard bone. So keep that in mind when you're looking at this chart, what medication you should be on. Okay. And I think the best way to kind of illustrate this is with an example. And this is my real life example. I'm 59 years old now. I was 58. And when I first started, my T-score, lumbar spine minus 3.1, femoral neck minus 3.7, I wish 3.1. Femoral neck minus 3.1, total hip, and distal 1/3. And what I'm trying to do is get into the safe zone, right? I got to get into the safe zone. So I need to pick up 17% bone mineral density to get into that green zone in my lumbar spine. So here I am here in this red zone. I'm looking at these medications. Yeah, alendronate after 5 years is not going to get me there. Reclass after 6 years isn't going to get me there, right? Prolia, yeah, you know what? It's getting close, and after 10 years I could get there. Or you know what? I want to get out of this area quickly. So I'm going to take these drugs first, right? One of these, if not more than one of these, but I'm going to take Evenity and hopefully move me down even into the osteopenia range if everything went absolutely perfectly, which it didn't, because I have hypercalciuria and I can't fix it. Haven't found out a way to quite fix it all the way yet. So I did drop down, but not very much. I dropped into this kind of high zone here, and I switched over to Prolia. Now, could I have gone over to, say, Forteo or Tymlos? Yeah, but I had a feeling it wouldn't work since Evenity didn't work and Prolia works in such a different way that I thought maybe it would make a difference. Besides that, because I already have hypercalciuria, the PTH class drugs can increase that urine calcium. I didn't want to have that happen. So I made the choice to go to Prolia, and I will be on Prolia for probably the next 10 plus years, right? It's going to take time, but I'm moving the right direction. And then once I get down in this low zone, then I'll switch over to the Lenronate. It's going to bounce up a little bit, and that's expected when you come off of Prolia. And then I'll get back on drug and it'll come back down. Okay. All right. So that's kind of that real life kind of look at things. But again, you have to look at the hip, because the hip here, well, femoral neck is the hip, right? 11%. I could never get there on a Lenronate. I could never get there on Reclast. I could get there on Prolia after, 12 years, right? So I need a boost like Evenity, 6.2% in 1 year. That would have been great. Didn't happen. But now Prolia will be the one that takes me there. Okay. So very important, these two slides, very important slides to understand. Right. Now we're going to move into, if you didn't think that was advanced enough, into how the medications work and how effective they are. So I'm going to show you those charts over, 1 year, 2 year, 3 year, 5 year, 10 years to see how the drugs work on bone density and why you don't want to stay, say, on a bisphosphonate too long. All right, so let's start with an example. Healthy person, well, it doesn't matter if you're healthy or not. This is happening in everyone, every day of your life. So this is happening. It's happening in thousands of places, if not tens of thousands of places throughout your body. And what happens is you have these osteocytes, okay? These are little structures inside your bone. And what they'll do, for whatever reasons, right? It senses a fracture, it senses a weak spot, it's flexing too much. It'll put out a signal that says, hey, I need work. I need some repair work done here. And what will happen is these osteoclasts will start to form. So it sends out a signal. The signal's picked up actually by a stem cell. And it will convert into an osteoclast, and it will continue to build and grow. And then what that osteoclast will do is it'll attach to your bone and start eating, right? It'll start grinding up bone. So bone is now being dug up. And calcium, phosphorus will all go into your bloodstream. And that's what they're supposed to do. So I'm trying to show that here, where this is the original starting level of the bone. Now these osteoclasts are moving across, and you can see how much lower it is. And then after the osteoclast kind of eats away the bone, clears the bone away, then these osteoblasts will start to form. They'll form behind it, and then they start laying down this collagen matrix, and they grow upwards. So they'll show up there in the bone, and they start kind of rising up with collagen matrix below them. And then as they get towards the top, some of them will just flatten out, and they will cover the bone. You get like a bone lining of these kind of flattened osteoblasts. Other ones will be left behind, and you can see it kind of left in this collagen matrix, and they become the osteocytes. So pretty cool stuff, right? And then as this kind of marches along and the filling's going on, then the calcium and phosphorus that's circulating through your blood will then mineralize that matrix and give it strength and turn it into full-blown bone. Okay, so you get new bone. Life is good, right? Issue found, issue repaired, life is good. When you're young, you actually get extra bone built after it digs. And as you're older, the filling doesn't quite work as well. Either that or the osteoclast diggers go too deep, right? And there's various controls for this that we can kind of monkey with, and that's what the medications will do. All right, let's start with the bisphosphonates, right? The knee-jerk reaction. Let's put you on Fosamax. Let's put you on Reclast, right? This is how those work. So when you take those drugs, it gets in your bloodstream, and what it'll do is it has a real great affinity to bone. It will stick and coat your bones. So it's, circulating through your blood, it goes over the bone, sticks right to it. And what these are basically little kind of poison pills, so to speak, for the osteoclast. Doesn't poison you. It just makes these guys very unhappy. and they'll start to slow down, and they can even die off, right? And they'll break apart into pieces and be reused in other areas of your body, and that's fine. But that's how bisphosphonates work. It's very simple. You just put down this kind of drug on the bones, and when it eats it, it screws up the osteoclasts. They can't dig as deep. And guess what? The osteoblasts, they still work pretty well, right? They slow down as well, but they don't slow down as much as the osteoclasts do. And you end up increasing your bone mineral density. And you can see that kind of pictured over here, where all of a sudden our level was here, right? And now it's a little bit better. Life is good. All right, so that's how this type of class of medication works. And as far as the results go, like I showed you on that one slide that summarized them all, here's the lumbar spine on alendronate. And there's two groups here. There's a placebo after 5 years, and that's what this is. But you can see that, after 10 years, I'm still going up. I'm at, 15%, maybe 14, 15% in the lumbar spine. Life is good. Well, now let's look at the hip. So if we look down at the hip, we see, oh, wait a minute here. Right around year 3 or year 4, year 3.5, I'm starting to lose density, right? You'll never get above, say, around 4 on alendronate, and then your bone density will start to drop. Now, if you stop taking the drug, it'll drop faster, right? It's drops down basically to start after 5 more years, but that's not too bad. Okay. Now, there's other bone markers here on the right. I'm probably not going to have much time to talk about them. Just know it's a blood test that can be done to see how active your bones are at building and how active your bones are at digging, right? So this is a good measure. This P1NP measures the osteoblast activity, how well they're building. It's kind of a byproduct that can be measured in the blood. And the CTX, as it's called, measures how quickly your bones are, chewing up, osteoclasts are chewing up your bones. Okay, so that's what those are. We're not going to have time to go into that in much detail. Reclass, very similar type of reaction, but it's got 100% adherence because people get one infusion a year and they don't have to take the pill every week. So that's an option for sure. And this is a more powerful drug. It binds better to the bones, so it sticks around longer, which has its pros and its cons. But regardless, the lumbar spine, here's 12% after 6 years. That's a good number. That's over a full T-score. But the same type of thing happens here in the hip. Around 3.5, maybe 4 years, you get this peak, and then that's all you're going to get out of it. And that's, right around maybe 5% or, thereabouts, 4.3%. And you can see the markers over here. I put a note here in the upper right. If you are going to do this, be well hydrated. And there's some other tips I'm going to give you a little bit later on if you're going to start reclassed. All right. This only gets more complicated, by the way, so keep that in mind. Trying to do baby steps here, though. Prolia. How does prolia work? Okay, we have the same osteoclast and osteoblast. Okay. Well, what I didn't tell you is the signal that was sent out to start this whole process in the first place. And what the osteocyte will do is it will emit something called, it's a protein called rank ligand. And it's abbreviated here, rank L. And this rank ligand is a signal that says, hey, I need you to make osteoclasts. And it's also food for the osteoclast. So as long as the osteoclast sees this rank ligand, they're going to dig. And the more rank ligand they see, the harder they're going to dig, the deeper they're going to dig, right? It's a control system in the whole process. And then once the osteoblasts start forming, they too can say, hey, you're not digging enough, and they can put out this rank ligand as well. But for the most part, we're trying to slow these guys down. So what Prolia does is it's a monoclonal antibody. And what it does is it gets in the bloodstream and it sees this rank ligand and it attaches to it. And it makes it so the osteoclasts can't use them. So it's an elegant design, right? To say, hey, if this rank ligand, too much of it is causing too much digging, hey, let's slow it down. And that's exactly what it does. And it works really well. And it works 10 plus years. There's no sign, actually, no study that I've ever seen or that doctors have talked about where this action stops working. So life is good here, and that's how it works. And you get a net bone density increase with it. Life is good. All right. Not so bad after all, huh? And now look at the study. So here's the major study for Prolia is called the Freedom Trial, and there's an extension trial as well that followed it. And you can see on this drug, oh my goodness, look at that lumbar spine. Better, 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 better. 10 years, still going up, right? Life is good here. Same with the hip. And, no other medication you can take past 3 or 4 years where your hip isn't going to start falling and, having problems. So this is a wonderful drug to have in our arsenal to fight osteoporosis. All right, 2 for 1 here. Teriparatide, abaloparatide, Forteo, Tymlis, right, the brand names. How do these work? Okay, well, PTH, when it gets in your bloodstream and it reaches your osteoblasts, it will stimulate the growth of those osteoblasts. It kind of energizes them. Now, it's a PTH, right? Parathyroid hormone, which I know I told you is bad, but stick with me here. If you give it in an intermittent fashion, you say, here's parathyroid hormone, right? Then you wait till tomorrow and you say, here's parathyroid hormone. It only stays in your system for minutes to maybe an hour. And what that'll do is it juices up the osteoblasts. And at the same time, it doesn't give that advantage because PTH also works with the osteoclasts, right? Actually, it gets technical, but regardless, if you pulse PTH, the osteoblasts say, hey, okay, I'm going to work on that. And the osteoclasts, they don't know what happened, right? I'm kind of slow reacting. So I missed that signal. And the wonderful thing about that is you can build bone mass, right? These guys are energized. Now, there's something else PTH does, and it will lower another protein that gets emitted by the osteocyte. So PTH will also lower what's called sclerostin. And I'm going to talk about that in more detail here in a couple slides, but just know that this too will help the osteoblasts work better, and it doesn't help the osteoclasts work better. Matter of fact, it actually makes them work worse. So that's a wonderful thing. Okay, so hold that thought. Let's take a look. Let's compare these 2 drugs in a trial. Here's one after 18 months. You can see Tymlis, which is a abaloparatide here. Tymlis working a little bit better in the lumbar spine than teriparatide. In the hip, you can see this is where it splits more, 3.2 versus 4.2. You get a little bit better on Tymlis than you do on teriparatide. And if you look at the bone resorption or P1NP and CTX, you can see kind of the difference on how they work here, but it gets pretty technical pretty quickly. So just kind of stay on the left-hand side for now. Which takes us to Evenity. So Evenity, I think, is the most elegant way. And there's no wonder in my mind on why this is so effective. Oh, by the way, just a piece of history. Apparently, they came up with this drug from some people in their Dutch origins, where they have this genetic defect that prevents sclerostin from being in their bodies. And these people, they'll get T-scores of +4, +5. And it becomes a problem, all right? The bone building gets out of control. And they said, geez, I wonder if we can inhibit the sclerostin and have it work. And sure enough, it works really well, at least for a while. And I'll explain that too. So getting back, when your bones or when your osteocytes say, hey, I need some repair here, it'll send out the sclerostin. And the sclerostin will attach to both the osteoclasts and the osteoblasts. And what sclerostin does is for the osteoclasts, it says, dig deeper. And if it hits an osteoblast, it says, don't fill as much. So sclerostin is a double whammy, right? If sclerostin gets in your system, it's like, oh my God, it's speeding up the diggers, it's slowing down the builders. This is the bad stuff. So what they did is they came up with this monoclonal antibody called romosozumab, right? Now trade name is Evenity. And it will attach to these sclerostin proteins and make them unavailable for the osteoblasts and the osteoclasts to get. And that's a wonderful thing, because now we've just done both. We've sped up the builders, we've slowed down the diggers, and boy, you could build a lot of bone in a short period of time. And we see that in the trials. Now, this is a 1-year trial, and there's reasons for 1 year, and I'll show you that in the next couple slides, if not the next slide. In 1 year, you can gain 13.7% in this study, in the lumbar spine, 6.2% in the total hip. The P1NP, this is the only drug that you can take where, at least for a while, your bone building markers go up and your bone digging markers go down. So it's the best of both worlds. Life is good, things happen here, and you're building back that structure at the same time as you're adding density. And it happens very quickly. Okay. All right. Now, well, Evenity sounds great. Well, I just stay on that until I'm normal. Well, there's a problem with that. The body's pretty smart, and it doesn't fall for this stuff for very long, apparently. So let's look at Forteo first. Forteo, it's something called an anabolic window that you might hear about. Probably not. I've never heard it from a doctor, but in all the trainings, they talk about this. And what it is it basically shows the two markers. So your bone building marker, that P1NP, when Forteo, that you're taking a shot, right? And Tymlos as well, you're taking a shot every day, you're fooling your system. It builds, but then after a while, the osteoclasts say, hey, I know what you're doing here. And they start kicking in, and then you lose the bone building capabilities, right? It's digging as quickly as it's building, and therefore you get, no benefit. Tymlos has a wider window, so maybe Tymlos you could take a little bit longer. And that, therefore, it's a little bit more effective. You can see kind of from the charts here. And then Evenity, again, the only one that actually increases the building and decreases the bone churning, so to speak. But again, over time, it loses effectiveness. Now, I have seen trials where they go 2 years and they're still gaining bone, so that's good news. But you know what? We can use Evenity down the road again if we want to. So life is good. Keep that in mind. All right. I said I'd give you just a quick commercial on estrogen. This is a chart that Michael McClung, that's his picture down there, presented at the World Congress of Osteoporosis last year. And he showed how estrogen therapy, or estrogen plus progesterone, if you have your uterus still, will give you very good results. And you can climb and gain bone density on, just this hormone replacement therapy. However, when you stop it, just like when you went into menopause, you'll lose bone density very quickly. And you can, like in a year type of thing. Now you might be saying, well, God, why isn't anyone talking about estrogen? Well, back in 2002, the Women's Health Initiative came out with a trial, a study, a huge study of hormone replacement therapy. And it scared everyone off of hormone replacement therapy. And it was really the fault of the media more than anything on hyping up some statistics and making it look worse than it was. And as a matter of fact, if you want to watch a video with one of the primary investigators, I've put a link here. And she's talking to a doctor that I follow, Dr. Peter Attia, and he's very pro hormone replacement therapy. And they go back and forth and talk about the results and why the results really back then don't really apply now. And a big part of that is the study didn't use bioidentical estrogen and progesterone. It used some synthetic versions that had some issues. And but even that said, even with those different estrogens and progesterones or progestins, the study showed that on drug, right, on the hormone replacement therapy, five cases of breast cancer per 1,000 people. You think, wow, okay, well, that's, unfortunate, right? It's not horrible that 5 out of 1,000. I like the odds here so far. And then you compare it to 4 cases out of 1,000 on placebo. Well, shoot. So we're only talking about 1 case in 1,000, maybe, on this older type of stuff. But the press picked up on it and they said, hey, 4 versus 5, that's 25%. You have a 25% chance of getting breast cancer if you go on hormone replacement therapy. It's like, oh my God, 1 in 4. No, it's 1 in 1,000. So things got twisted out. They talk about that in the YouTube video. And then, by the way, there was no increase in breast cancer mortality on this either. And oh, by the way, there was a decrease in fractures, including hip fractures, the reductions in other types of cancer. Um, Estrogen is wonderful to clear your head, right? Night sweats, if you have them, it's great for the heart, it's great for the brain, it helps prevent Alzheimer's. I mean, it is the superpower of women. So it's a bummer when you lose it. So if you haven't even considered it and think you might want to consider it, what I did is I put a link here, and it's called out by this principal investigator, a menopause organization where they have a directory and you can go and find someone that's a hormone replacement therapy expert, right? Your doctor, your primary care physician, he's still thinking about this 2002 study, causes breast cancer, don't go on estrogen. Okay, maybe not. So get smart here because this could be a potentially good option for you. Few words about adverse reactions. Let's talk about Prolia because that gets the most kind of heat. And if you look through the Prolia warning label and other documents and horror stories you hear from your friends, right? The number one adverse reaction is back pain. You go, oh my God, I got enough back pain. I don't need any more back pain. Forget that. I'm not going to take that. And if you look at the study, this is a study that was done with on Prolia, 3,806 people, 886 people. And of those almost 4,000 people, 1,347 of them had back pain. And you think, wow, that's 35% of the people had back pain on Prolia. That's pretty serious. Well, yeah, until you look at the placebo group. So the placebo group had almost 4,000 people in it, and it had 1,340 people. So the same 34, 35%. So back pain, while it has to, by the FDA standards, it has to be listed. If you have more adverse reactions on drug versus placebo, it has to be listed. But just look through the fine details to see how serious these side or how prevalent these adverse reactions are for the various medications. And it'll help you feel better about, boy, maybe that is worth the risk, right? Okay. All right. And then finally, reclass, because it's so popular, a lot of people on reclass. If you're getting ready to take reclass, I traded emails with someone today on getting on reclass in the next couple of days. This is a slide that Dr. John Belazikian presented. And he basically said, hey, look, when you're going to take zoledronic acid, it's an infusion, you get it at a center, about 15% of people get kind of fever. You get flu-like symptoms. About 15% of them do on their first shot. The next year, when they get their second shot, only about 2 people have an adverse reaction to this space. And then it goes down to 1% for the third shot. And likewise, muscle aching, flu-like illness, headaches, joint pain, that type of stuff. You can see it across the board here. He said that for his patients, he recommends Tylenol for 3 days, one day before you get your infusion, the day you get infusion, and then the day after, and that will help with some of these, potential symptoms that you get. Kind of no harm, no foul. Okay, last slide, summary. Sorry for the time, I'm sure I'm over, I'm almost over. 5 steps to build solid bones and peace of mind. All right, so I'm just gonna recap here. Guys, you will save so much time if you can find the right doctor. I know it's difficult. There probably isn't one in your area. You might have to drive an hour. I have to drive an hour, right? And my appointment's not till August, and I made it last year. So they're really tough to find, but you really want to try to find an endocrinologist that specializes in osteoporosis and get that person on your team. Okay. Before you start medications, try to find out why you have osteoporosis. Get that blood test, get that urine test. That's a must-have. You've got to fix any kind of problems that you have before you start treatment to get effectiveness. Okay. Decide if the risk of medication is worth the benefit. Now you're going to make a decision on the medications. Know that your risk of fracture typically almost always outweighs the risk of an adverse reaction. So, take it seriously, but it is a drug. Who knows what they're putting in there? All right. I didn't mean that. Choose your starting medication based on your long-term goals, and order matters, guys. Again, Don't fall for your doctor saying, oh, we'll just put you on Fosamax and then we'll see what happens. If you're in that high risk zone, you've got to get out of it quickly. And going on that first is just going to slow you down, because when you take the drug you're supposed to take, right, the osteoanabolic, the effectiveness will be reduced. And I have some slides in the backup that shows that, right? And then before you start, right, like when I finished Evenity, I got a DEXA scan done. Right before I finished, I got a DEXA scan done just before. And then that way I knew what to transition to at the end of that treatment. I know I needed to go to Prolia. And, right after my treatment ended, I started Prolia. And I'll be on Prolia again for like the next 10 years. So I don't have to worry about it. Well, I will. After two years, I'll check, make sure it's working. All right, with all that said, I apologize again for the time. I'm sure I'm over, but thank you very much. And we can open it up to questions, and I can go through some backup slides too if you'd like.